Director for the Illinois Coalition Against Sexual Assault and formerly the Director of Community Impact at United Way for Central Illinois. A 2011 graduate of Quincy University's, Ms. Hayes' work has focused on the critical intersection of social emotional health, impact of trauma, and existence of critical community support. Ms. Hayes, the floor is yours, and I'd love for you to introduce us panelists. Thank you.
Hello. Hi, everyone. I'm always in that weird height. Sometimes I think I'm shorter than I am, and then sometimes I'm way shorter than other people think I am. So how's the volume? How's everything? Good? Perfect. Awesome. Well, first off, let me just say I am so incredibly honored to serve as the monitor to this panel discussion with these amazing individuals up here today. As Vishrit shared, my work, my history thus far has really sat in this critical intersection that these wonderful individuals are doing amazing work in. And so I'm truly just honored that I was asked to participate in this way. So who's up here? Who are these amazing people that we are going to hear from this afternoon? Well, this mid-morning. So Amanda Walsh is an attorney and social worker with expertise in social determinants of health, mental health, trauma, public benefits, child welfare, and education. She is the director of the Illinois Children's Mental Health Partnership, where she organizes statewide experts, legislators, and state agencies in collaboration building, policy development, and monitoring around child and family well-being. Previously, Amanda was a staff attorney at the Legal Council for Health Justice, where she started as an Equal Justice Works Fellow. There, she established Illinois' first pediatric behavioral health medical legal partnership designed to improve outcomes and address the social determinants of health for families living in poverty. Dr. Ann Scheer is an assistant professor with the Human and Community Development Division at the Department of Population Science and Policy at the SIU School of Medicine. As a childhood sociologist, Dr. Scheer uses a qualitative and mixed methods framework to explore and understand children's own views and voices across a broad range of topics related to children's mental and physical health and well-being. She has conducted extensive research with elementary school-age children using participant observation, interviews, and art-based methods to actively engage children in the research process. In her current work, Dr. Scheer is leading a large-scale collaborative project designed to transform one of the communities in SIU School of Medicine's service region into a UNICEF-recognized child-friendly city. Angie Bailey is the System Director for Community Health and in the Community Benefits Department at the Southern Illinois Healthcare, a nonprofit hospital system. She provides coordination and leadership in the Community Benefits Department as she and the CB staff work together with community partners to improve the health of the residents of Southern Illinois. She has led the development and implementation of 6 community health needs assessments. Angie received the Illinois Public Health Worker of the Year Award in 2014 from the Illinois Public Health Association and the Stephen Westbrook's Excellence Award in Rural Public Health from the Illinois Public Health Institute in 2012. Dr. Colleen Cicchetti is the Executive Director of the Center for Childhood Resilience, a clinical psychologist at Ann and Robert H. Lurie Children's Hospital of Chicago, and an associate professor at Northwestern University's Feinberg School of Medicine. In addition, Dr. Cicchetti serves in a leadership role in numerous state and advocacy groups, including clinical director of the Illinois Childhood Trauma Coalition, appointed member to the Illinois Children's Mental Health Partnership, and Hold Child Task Force. Wow, are we in for a real exciting conversation this mid-morning? So thank you all so much. So to get us started, we want to kind of get the panelists' general take on the current state of rural children's mental health and how the pandemic has impacted the health and wellness of our young population. So to get us started, Dr. Cicchetti, would you start us off?
Hello? Okay, thank you. So the state of children's mental health. I think we heard some pretty dismal reports from our last two speakers in terms of there's a seriously high need for children's mental health to be addressed in our state and in the country. I think one of the things that I have looked for, as I heard both of them allude to, is where is the positive or the silver linings of the pandemic? I'd say the silver lining for many things related to children's health is that the awareness of the importance of children's mental health has never been more obvious. I think the pandemic didn't change children's mental health necessarily, but it highlighted the need. And we've moved from a state where lots of folks were saying, this is not a problem in my community, to the moment where people are saying, oh my goodness, this is affecting my loved ones, my neighbors, my own children. How are we going to pull together the resources to fix this? So I think the positive of the crisis is that we've seen the rates and the demand for services go through the roof, and that has exposed the barriers and the gaps in service delivery models. So I think it's really a time for change and an interest in change that we haven't seen before. But I do, I want to be really clear that some of that data that was up there, we have a mental health shortages in almost every county in our state. In fact, 95% of Illinois counties are designated mental health shortage areas, and it's even worse for child. So that data was for adults, but for children, it gets worse. There's only 81 counties in our state that even have a child and adolescent psychiatrist. And about 90 or only 50% of schools in Illinois have a school psychologist that's designated in their building. So when we talk about a mental health, behavioral health shortage, it's really real. And I think that the good news is that I think we're working together in creative ways to try to address that. And many of the people on this panel will be able to talk about what we're trying to do differently in terms of how we're going to address this mental health crisis. But it's real, and the time has never been more important.
Thank you. Yeah, I'll add on to that. So, we hear a lot about children's mental health and the crisis that we're in children's mental health. And as Dr. Cicchetti emphasized, this wasn't a crisis that came about because of the pandemic. It existed prior to the pandemic. I think, though, what we also have to keep in mind is that we're talking about a spectrum. So you heard in the opening remarks about the need for more comprehensive care, looking, how many generalists do we have? When we're talking about children's mental health, so many people are focused on the crisis treatment end of the children who have the worst conditions or need the most intensive services. But what we're seeing is increased rates of depression and anxiety across all of our schools, and that these aren't the kids that are going to be needing those crisis services. So how are we thinking more upstream? How are we dealing with our issues that the pandemic emphasized, like having more school supports, thinking more about access, like through internet access and telehealth. So I think that is one of the things that's really I find very striking about what the conversation around children's mental health is right now.
I'm not generally looking for the positives. I'm looking for the things that can be improved. But one positive that I have noticed that I do want to emphasize is through the pandemic, at least the emails coming in my inbox suggest that there has come an increased awareness of the need to listen to communities, and as such also by extension to listen to kids, which is very positive for me as somebody that does this for a living. I work with kids of pretty much all ages, primarily 5th grade and up. And my job, first and foremost, is to listen to kids' voices and to give their voices a place in academia and outside of academia. And it does appear that the pandemic has given these voices a special place because we realized that the things we thought should work didn't work. And we're now trying to figure out why. And that is part of the path to solutions, which I think is something very positive. The other thing that I can just relate based on my conversations with kids that I think not all adults always are as aware of as they need to be, is that when you're 12, 13, 14, those 2 years represent a much larger part of your life than for people of our age. And so you lost 2 years of your life, which is a much higher percentage. And the rites of passage and the important parts that they lost out on, whether that's, freshman initiation or a prom or a homecoming dance, those things are hugely important. And I think if all of us think back to our days when we were in elementary school, in middle school, in high school, we can really remember or try to remember what it felt like to be part of that, and just to try to understand what it means for kids to miss out on that. And then one thing that a girl shared with me, who is a high school student, we were supposed to stay away from people for so long and, don't interact and stay 6 feet apart. And then one day schools opened up and we were supposed to just be normal again and interact and hang out with our friends. Plus then the added pressure of, performing academically and producing results. And so I think it's very, very important to understand why kids are struggling and why it's hard for them. And the schools that I'm working with are seeing an increase in, what they call behavior issues, but where are they coming from, right? I think all of those things in a very, very complicated way contribute to what we then see surface as those manifestations. And I think it's very important to be compassionate and empathetic.
So lots of information shared already. In Southern Illinois, during the pandemic was our time. Many of our local health departments in our organization completed our community health needs assessment. So Dr. Vora had talked about health departments and community healthcare organizations working together on our assessments. Nearly everywhere in Southern Illinois, the lower 16 counties, everyone noted mental health on their community health needs assessment, whether it be hospitals or public health. And so seeing that, and then also talking with teachers, we work with schools throughout Southern Illinois to talk about mental health and work with them through COVID. But what we're seeing and hearing from the teachers and the school staff is not only differences in their mental health, but social and emotional learning that was alluded to, just ability to speak with others and talk with others and just have general social skills because they did lose that during the pandemic. The other thing that we kind of can see is the differences in how the pandemic impacted different people in different social determinant levels. So those that were considered the haves had resources for childcare and resources for their families. Maybe they had computer and internet access, where those who were in the lower socioeconomic didn't have these things and were really struggling more, maybe with that connectivity, meeting, the needs of their students, those that learning. Those differences have really been impacted, and we can see that more as well. So I think back to the celebrations and all this is we're seeing more schools and more community agencies working together on these issues, continuing to put funds and resources. In Southern Illinois, we don't have psychologists at any schools, and your wait list can be months and months. And if your child is brought to the ED for a behavioral health or mental health crisis, they may be taken 6 hours to a Chicagoland hospital, and you're the family that is in Southern Illinois. How do you see your child and help your child when they're taken 6 hours away for an inpatient treatment? So I think we've seen lots of differences and changes, and I think we'll continue to see this over the years in both urban and rural areas and how this has impacted our youth.
Thank you so much. And so, this question was really tailored around the pandemic and the effects of the pandemic, but we know policies and things impact children even before the pandemic. And so, Amanda, talk a little bit about or describe the impact of the Children's Mental Health Act of 2003 on the mental health of children in the state.
Sure. So to start to give background, back in about 2000, a group of stakeholders came together to look at needs around children's mental health. And through that task force recommended the creation of the Children's Mental Health Act of 2003. That act required a children's mental health plan be developed for the entire state. And then a partnership be created to monitor the implementation of that plan. So that's my job, is leading that partnership. And we just actually completed a revised version of the Children's Mental Health Plan. Director Vora was actually chair of the partnership at the time. So a lot of what you heard today really flows through the new plan. As far as the impact the original plan had on the state, it's pretty vast. So in 2003, no states in the country had standards around social emotional learning. Through the creation of the partnership and that original act and our partnership with the State Board of Education, we established the first social emotional learning standards in the country and mandated it of all school districts in our state. Now every state in the country has similar standards. It also created, if anyone's aware of, it's called Illinois Doc Assist, and that is also through our partners at HFS, which provides for pediatrician and primary care doctors working with Medicaid patients. It provides a hotline for you to call if you're seeing mental health issues in the children or parents that you're seeing. We also established an initiative to test a workforce development around mental health consultation. So really looking at early childhood settings in particular, how do you work with providers who are providing services but might not be mental health professionals? So is there a way to support those providers in the absence of those mental health professionals to better serve the children that they're with? So that's just some of the work that the partnership and through the Children's Mental Health Act of 2003 accomplished. As I mentioned, we just finished almost 2-year process to develop a new plan for the state, which echoes everything we've heard from the presentation so far. So I'm excited for that to be implemented and see where that goes.
Thank you so much. And so, Angie, to you, so in your role as a community health professional, Amanda just shared a lot about these standards that were created. What are some of the innovative programs you've come across that have helped put children's mental health first?
Okay, is this one working? Okay, great. So one of the things that we work with through our Southern Illinois Catch On to Health Consortium that works with local health departments and SIH and the School of Medicine, Center for Rural Health and Social Service Development in Southern Illinois is the whole school, whole child, whole community model. I don't know if everyone's heard of this, but it's a model out of the CDC that really looks at 5 tenets for students. And what can we do to make sure that students are experiencing and able to achieve success in school? So really looking at making sure that they're healthy, safe, engaged, ready to learn, challenged, and supported. So in doing that, we work with schools on the School Health Index, and there are models and sections in that where in Illinois, it's required that schools must have a wellness committee. The wellness committees can go through something that's the CDC School Health Index and look at what are the curriculums around mental health and social and emotional learning, and then what supports are in place. So do they have social workers or counselors or individuals, and what do they do if they see a child in crisis? It's really a whole child model. So that is implemented. We also implement things with our schools and are working closely with the ROEs and the school district superintendents around implementing mental health first aid for youth and mental health first aid for adults. So that is a program where they receive training to assess and know what to do, what signs and symptoms to look for in children and adults in their communities, and then what to do to refer them to other agencies. So that's an 8-hour training one day. We have many trainers throughout Southern Illinois. Some school districts are making it now mandatory for their entire schools to complete that. We offer it to faith-based organizations, just general community members. We have had just a story, a community partner who we'd worked with for years. She had attended the training and noticed that some of those things she learned about, she was seeing in her own daughter. So she went and spoke with her, and the daughter said, yes, Mom, I have been thinking about committing suicide, but I was, I had my plan, I was ready. And so the mom was then able to intervene. But prior to this training, she didn't know the signs and symptoms to look for. So we're seeing those successes throughout Southern Illinois in connecting individuals to resources. Another thing that we're doing is signs of suicide training. So we can implement that with schools, or schools can be trained and implement it themselves. So we have been doing online training for school staff. So what signs of suicide is, and it's developed through the National Mental Health Alliance, is students complete an assessment in class, and we work with the school social workers or health teachers or whoever it may be. They complete that assessment in class, and then they receive a lesson in class. And what we're finding that is 95% of students are expressing that they've learned something about how to help someone and how to better look for signs of suicide in their own classmates. And then with the assessments, the school staff can then get those back and then see if there's certain students that they need to reach out to. So that is being implemented across various schools in the lower 16 counties through the Illinois Catch On to Health Consortium. So that's just an example of 3 different programs that we're working with schools on in Southern Illinois.
Katrina, can I share some of
Absolutely.
the, I think what we heard earlier is that there's also been these opportunities. So all the great stuff that she was just talking about has existed in funding streams that start and stop. One of the things that we are really interested in, the partnership talks about a lot, is how do we move from those sort of short interventions or a grant program that goes into one place and then disappears, and then it leaves the community actually in worse shape than when it got there in the first place. So one of the things I just wanted to talk about in terms of some new interventions or new resources is with some of the ESSER dollars that came through, so the emergency dollars that came specifically to schools. We've been able to take a project that we had been piloting, looking at how can we create some consistency across the state. So the project is called REACH, or Resilience Education to Advance Community Healing. And what's exciting about this project is that there was funding that went to us with a group of people and partners across the state to build this. There was funding that went to the regional offices of education to create 6 hubs to really bring this across the entire state and not just in pockets. And then now there's some funding that was released to specific communities that have additional needs. So what we're seeing is money going out to multiple sectors with a goal of creating a coordinated effort. And so what REACH has been able to do for us is to start to think about what would happen if we had a common assessment tool to think about our schools creating the supports that they need in a consistent manner. We're using a measure that's available for free. So any school in the whole country can go on board and do something called the Trauma Responsive Schools Assessment. And then they get a picture of where they are across these 8 domains. And through that, they can create action plans of what they want to move forward. So what we're doing in Illinois is we're actually creating networks to guide schools through that process, using the regional offices of education hubs to select schools to do this work, to get them through this process, create these action plans, and then coordinate so that every educator in the state has access. So when we talk about the rural part of the state, it's really important. One of our big partners is our colleagues from the Stress and Trauma Treatment Center in Southern Illinois, because we really wanted to make sure that this was applicable to everyone. So in this work, what we're really thinking about is saying, what if schools could say, this is what I need in my particular school to create more supports for students at the universal level, at the targeted level, or bringing in community partners, and then helping them build that capacity. So we've created a website that's had over 6,000 educators log on. It came from emergency dollars, and it was all about helping educators deal with what they were seeing in the pandemic, but it's building off of that. We've also created these communities of practice so people across the state can come together. It used to be really hard. As I'm a trainer for one of the interventions that we know works in schools, it's really hard for small districts to pay for someone to come in and do a training for 2 people. So what we just did is we launched a training for 50 clinicians across the state virtually. And we've got all these clinicians that wanted this that couldn't access it before. And not only did they get 2 days of training, Now they're going to be working together to build their practices and figure out the problems and figure out how to make it feasible and work in their own agency and in their own community. So I think what we're seeing is this idea that we can't just take the federal dollars and build something and then have it go away. We really need to build these networks where we're all working together. And I think with REACH, one of the final goals of it is to create in the next year a certification or a rubric that's actually going to tell parents, is your school doing these things to support your students? And what are their strategies? How are they doing it? So that we can put that out there and then direct state funding to those places that need more assistance and also to those programs that we know are working. So I think it's just it's an exciting, this is one of those places where the emergency funds are helping us, but we were really in a place where these opportunities were happening already. But with this, we're able to build something that we can coordinate. And we've got leaders at both ISB and through Samir and Dr. Bora and his work. We're really seeing people coming together and saying, how do we make sure that this doesn't go away? And so I think going back to what Amanda said, 2003, we were ahead of the game on SEL. Now, if we can get ahead of the game on actually putting some teeth behind what these services look like and a way to talk about it, we will put Illinois back out in front again. And so it's exciting around that as well.
Absolutely. And, when I hear about consistency, there is nothing I love more coming from my previous role as director of community impact when we have some standardized assessments, because we can then kind of talk across sectors and talk across systems. But what we also know through our work, and all of you are very aware of it, is that everyone has a unique story. Our children in our rural communities all have unique stories. Those stories create community cultures. Those community cultures can all vary based on, histories and disparities. And so I want to put the next question over to you, Dr. Scheer. How can we equip communities to make children's mental health an important part of health equity initiatives in small towns and rural regions? Because I think that equity piece, and Dr. Cicchetti, you really started talking about it, how not every school is equal with their access to resources, but taking it even deeper into that equity initiative, what does that look like?
When I read the question, I was wondering if I had the rest of the day to answer, but I don't. So I'll try to keep it as brief as possible. I think we need to think about mental health and children's mental health in a bigger and broader way. I'm a sociologist, not a clinical provider, not a psychologist. For me, mental health is more mental well-being, and it starts long before we're talking about a DSM diagnosable issue. Before it's something that is noticeably damaged, before it's something that requires a fix. And so kids need access to, it's not rocket science. They need access to safe places to play, to safe places to hang out after school, to adults that provide a stable role in their lives, to after-school programs, to community centers, to community I work in, really doesn't have that. And I'm sure there are others like that, and more than we think. And that being said, children are not a homogeneous group. So it's been said a few minutes ago, when you have access to resources, you can sign your kids up for after-school programs. You can sign your kids up for activities. You can pay for the equipment. You can pay for the trips, for the tournaments. But there are lots and lots and lots of parents who can't. Not that they don't want to, they can't. And so those kids need supports. And they need that as a preventative measure so that they don't get to the point where they need a fix. They get to the point where it becomes a DSM diagnosable concern. I also think we need a more open dialogue. Personally, I would have a hard time thinking of close friends that I know that don't have mental health concerns. Lots of them take medication for it, and yet it's still often stigmatized. I think if it's not at some point people like us who are out in public who start destigmatizing and saying, yeah, this also affects me, then how are we going to expect our kids or people who struggle with all kinds of other things to open up and say, okay, yeah, I do need help with this. And then finally, kids need families and neighborhoods that thrive. They need, it's a I work directly with kids, but they don't live in a vacuum. They need a family that, a mom, a dad, a caregiver, whoever it is that is responsible for this child's care, to be happy and healthy and safe so that the kid can be happy, healthy, and safe. They need a neighborhood that is a place where everybody can be happy, healthy, and safe. And again, it's not rocket science. We don't have to have these latest, greatest tech inventions. It's the basic stuff. It's a playground that you can go to and be safe, and you can return home safely. To me, that is a fundamental investment that is needed. And it is costly, but it's necessary.
So yeah, just kind of opening it up then to any panelist who wants to take this question first is, so what do kids need? What can we provide through programs, and then to kind of take it that next step, policies to improve mental health?
I'll start.
Yeah.
I think building off of what was just said. So when we developed the new children's mental health plan for the state, we spoke and surveyed parents and adults around the state as well as youth separately. And what was really striking was the differences between what youth said they needed versus what the adults said they needed. Adults identified things like access to mental health services. That was not something that youth identified. What the youth identified, the main things that they identified that they need is, first, they need education and language around what are these issues. I think it's really striking that we talk about social emotional learning versus mental health education. You know, imagine if you're 12 and you're trying to understand those two things, and why are they classified differently? Why are they paid for through different kinds of funds? If I'm struggling with depression, but I don't think it's bad enough where I have to go to the emergency room, I might not see it as a mental health education or issue. So kids identified the needs of that they simply don't know how to talk about these issues on a full spectrum, particularly with the adults that they're working with. The second thing that the kids identified that they needed was support programming. So exactly what we just talked about, that we need more after school programs, that we need to invest in those programs. Again, not the services themselves or the mental health services. So kids are very, very wise in what they need, and they identified that as the second top thing that they needed to help support that. The other thing that was really striking was how they identified social determinants of health. They didn't say it that way, of course, but they identified social determinants of health when, again, that wasn't something we saw come out as one of the main issues from the adults that we talked to. The kids were able to say, I can't deal with this because my parent lost their job, or I can't deal with this because we can't get somewhere. So they're aware of, again, the fact they don't live in a vacuum and how all of these things are coming together. And again, they might not be talking about it in that language, but they're very aware of it in a way that's very unique and very different than how us as adults are used to thinking in siloed systems. So I think when we, it's already been said, we need to listen to kids. We need to listen to what they're saying they need, and then prioritize those needs in addition to trying to meet the high-end crisis needs that are coming up as well.
Yeah, I would second what these guys said and really think about by centering kids' voices and needs. One of the phrases that we've heard from kids is, I want to rethink safety in my school. And I also, for me, I want to rethink what mental health delivery looks like. So I think what we're talking about here is, how are we building exactly what Ann said? We need safe, supportive relationships. The CDC will tell you over and over again, the best protection against stress and trauma is the existence of strong relationships with adults in your community. That could be from your family, or it could be from your educator or your Girl Scout leader or your youth minister or your soccer coach. So we need to really be thinking about how are we strengthening our overall community response to step up and step in and promote wellness and health. And that goes from investing in playgrounds to creating safe spaces. So when I think about the mental health crisis, I frequently say we cannot mental health our way out of this. There's never going to be enough mental health providers to deal with all of the needs. Instead, we've got to do what we're all talking about, which is this public health approach that really says, what is it that all kids need? and they can get in their Head Start programs and their early childhood programs if we train the teachers early on what are the critical supports that families and kids need and make those available. Then once they get to school, it's taking the social emotional learning standards and saying, this is the vocabulary. These are the tools that you need. We all know, our employers are telling us, we need to have employees coming into the adult workforce that have the kind of skills that social emotional learning do. But we also have a mandate that's been here since 2003. But if you go into many of our schools, we're not going to see evidence of that mandate existing. So we need to move away from mandates and move towards how do we get teachers, administrators, and families to say, I want my kids to learn to read and write, but I also want them to learn how to social problem solve. I want them to learn how to assess their emotional state and ask for help when they need it. And I need the adults around them to be able to respond when that happens. So a lot of the work is really rethinking that, thinking not just about teachers either, but thinking about those out-of-school providers, thinking about these folks that have long-term relationships with kids. Think about the people in your own kids' lives that have known them forever. I had dancers. Those dance coaches were involved in their lives from when they were 5 until they were 18 years old. They knew them better than some of their classroom teachers. So how are we thinking about investing and training all those different people? How are we thinking about bringing those services and creating systems? So if a teacher says, I'm struggling with Amanda, I don't have to feel like I'm alone and I'm just a bad teacher because she's not doing well in my class. I have a system where I can go to the school mental health council or the school behavioral health group and say, this kid's struggling. I'm trying and using every tool I have. What do we do and have in this community to build those resources? So I think if we start to be more creative in developing those systemic opportunities to think it through, we can really give kids what they're asking for. For some kids, they don't need a mental health intervention. They need a drama program. They need a mentor who's going to show up every day and say, I'm really glad you're at school. So we need to rethink what we're doing and then match the right kid to the right intervention and be creative in who can deliver that. And I think if we start doing it in that way, we're going to start to see fewer kids needing those high-end services. But it really is rough when we have a system that doesn't kind of all work together until there's a crisis. And so we really need to be thinking differently about those investments.
So not to like interject, but I kind of want you to continue a little bit, only because you talked about move away from mandates. So what other levers do, our legislators have, our policymakers have at their disposal that you think could help better provide placement of children's mental health services in the community?
I think it goes back to what my colleagues have said. It's listening to what people are asking for. So from our perspective, for example, with the SEL mandates, I mean, we've gone around and looked, and some schools are really buying into it, some aren't. I think when we first put those out, there was a lot of emphasis on the social emotional skills of students. What we've actually come to realize is we've got to start first with the social emotional skills of the adults. And this pandemic has actually highlighted that because the teachers are saying, I am overwhelmed, I am stressed, I don't know how to meet the needs of my students, so I want help. So one of the things that we're doing is working with, for example, the Illinois Education Association and the Illinois Federation of Teachers to create materials and services and supports that they are in fact asking for. So it's really important when we talk about listening to the community and bringing services forward that this is not seen as some Lurie children's program that happened in Chicago up at Northwestern, but instead as a collective. So with the REACH program, we are in every single region of the state right now. We have over 225 schools involved. And these hubs and these partners are really trying to listen at the level of the community provider. So getting teachers to teach other teachers how they've addressed these things, getting parents to connect about what do I need to do to support my child in their SEL skills. So it's really, I think, about creating these moments to invest in the professionals and give them what they want and elevate their voices and pay for their time to get trained to do these things, because they sort of feel like another mandate's coming, I can just hold my breath and it's going to go away. And so we really need these comprehensive assessments. It goes back to the community health needs assessments, asking people what they want and then helping them co-develop what it is they want in their schools and not having it just seem like it's coming from some outside agency. I think we're going to get a lot better buy-in. And our hope is also by celebrating and supporting them to meet the goals that they've established. That's going to be a lot more effective than telling them what they need to be doing.
Absolutely. Thank you so much for allowing that little interjection. So Dr. Scheer, your kind of thoughts on what additional programs and policies we need that kids need access to improve mental health.
Well, good question. I think the key term here is sustainability. I think we've talked about this before. It can't just be something that goes away. If for whatever reason it goes away, it needs to be communicated to the community so it doesn't just disappear, because that results in disillusion and loss of buy-in, which then makes it more difficult to implement future programs. And rightfully so, right? They're not guinea pigs. So I think that that is super important. I also think that sometimes we make things more complicated than they need to be. I don't know that we need, it's not that we don't need innovation, but we don't primarily need innovation. We need to engage kids in helping design, whether it's an educational flyer or an educational program or just working with them. And I'm saying that, both from my role as an academic researcher, but also from a practitioner's perspective. Obviously, data is only as good as it's the quality of how it's collected, but it doesn't mean that data can only be collected or analyzed by somebody with a PhD, or that data that is collected by a PhD or an adult is automatically good data. So engaging kids in data collection, in data analysis, in interpreting data, in identifying priorities for what they want. And it's, again, I'm glad we are here now today and not 20 years ago, because there are more efforts in that direction than there were 20 years ago. But I think we still need more of it, because oftentimes the people we are trying to help, whether that is kids, and we're talking about kids right now, or adults with any problems, they are well aware of what they need. They just don't know how to get there. And they need technical support a lot more so than they need content support. When it comes to, more innovative things, Dr. Vora had a slide there that identified how many providers would be needed to fill the gaps, and that was not pediatric mental health, that was adult mental health. I suspect the numbers would be much, much higher if we looked at the pediatric needs. So in terms of innovation, telemental health or school-based telemental health is a possibility. But I looked a few years ago, at least in the research, there wasn't much in terms of what the kids were actually looking for, because they all have cell phones and they all like TikTok and they all like YouTube, doesn't mean they're comfortable getting mental health services that way. But under what circumstances might they be comfortable? What would it take? So things like that, where you really explore the possibilities we have in that field of technological advances that we have access to, but making sure that we take the kids on board from the beginning and not by the time we're ready to roll something out. And then something that I personally think, from my experience working directly with community members in high poverty and high need neighborhoods, is some form of low-level mental health support services that are offered through community members. Whatever you want to call that, a mental health community health needs worker, but the kids need somebody that looks like them, that they trust, that is available, that is already there. And let's face it, the shortage was there before COVID. It's worse now. The providers aren't going to fall from the sky, but we need them now, and the kids need help now. And the people, to a large extent, short of the kids that really need serious crisis intervention, which obviously requires a professional. I understand that. But there are a lot of kids that need a listening ear and need somebody to be there for them. And investing and acknowledging that those people already exist, but we need to systematically invest in them and train that type of workforce, because, like I said, we cannot, it took me 9 months to find a counselor for my child. And I work in healthcare, and I have excellent insurance and an excellent network. And they said, yeah, call back in 6 months. So just to think how long it would take somebody that doesn't have what I have, it's not going to happen. So let's work with what we have, is kind of my, I don't know, my vision, my hope, my dream.
Absolutely. And Angie, I'm wondering if you could talk a little bit about what your thoughts are on how hospitals could use community benefit dollars to kind of decentralize that children's mental health service into schools, into communities.
Yeah, so some of the things I mentioned already with the community health needs assessment is just making sure that mental health and those issues are part of the community health needs assessments, and that we're really putting our money behind that. In our community, we have had our community benefits department since 1995. And Woody had expressed earlier, it's really about improving the health and well-being of all the people in the communities we serve. So we do that through a variety of ways, working with community coalitions. We have a community health coordinator, a school health coordinator, and a health ministry coordinator who are all focused on those priority health issues. So behavioral and mental health being part of that. So trying to make sure that we have those ways. Some of the things that happen through that is our work through community coalitions to break down the silos between these different agencies and individuals. Because the mention of trying to get a family member into treatment, I mean, and what can we do within the agencies to help individuals and connect them to resources? We have things like community health connectors who are lay people who we just train on community resources. So it might be the church leader or the grandma that volunteers at the school who's trained, or others. So they're not community health workers, and we just call them connectors. So they know about the behavioral health resources or who to contact at the school, or, you know, this pastor is really interested in talking with students about that. But again, connecting people to where they are. So I think one ways hospitals and healthcare systems is to leverage those community benefit dollars in a variety of ways to help make those connections across all the different organizations, and can serve as a leader in that to reduce those silos. I mean, other projects we're doing are focused around helping individuals in crisis and getting law enforcement and the Trauma Stress Treatment Center and DCFS and our attorneys and the state's attorneys and the judges all at the same table, so they can really problem solve around an individual. And it's the healthcare system that's kind of helping navigate and lead those meetings and coordinate them and facilitate them, because we have the expertise. It's just getting them all together at the table to do that work. So I think those are some of the ways, just again, stressing that community health needs assessment and bringing in all the voices to get the input, to create the plans, and then you implement the strategies using the funds that you have towards that.
Yeah. And, you know, so again, reflecting on my own experience, I know like hospitals are also, when they are trying to invest those community benefit dollars, they may have not resistance. I wouldn't come from that space, but I think, you know, schools are overburdened, especially with the pandemic, and there's so many things that they are also having to do. So I guess, Amanda, not to put you on the spot, I wonder what you think about, you know, how can school-based communities help in promoting better mental health access, or maybe, you know, connecting with those hospital community benefit dollars to really create that, that connected system?
Yeah, I'll start to answer, but I actually think Colleen will be much better to think through this, working directly with the schools. One thing that I think, you know, that we talk about a workforce shortage, and as Ann was saying, it's not that we don't have the people. People are there. All the adults are there and they're around kids. It's how are those people who are already exist helping? And so what we know is for kids is really school is that central spot. And so how are we supporting the adults in those systems? What I think is really striking as we think about how to improve children's mental health in schools is again, we have systems already in place that are supposed to be doing these things. So we have multi-tiered support systems that are supposed to be recognizing when there might be struggles. But we also have the special education system, and that system is stigmatized in its own way. But you know, then you see bureaucracy of how are you eligible for special ed if it's a mental health need. but prior to my current role, I was a special ed attorney, and I spent an entire year trying to get a child who was suicidal, trying to get her services through special ed, and it took a year to get her eligible. But the school did not find her eligible under emotional disturbance, which is how we categorize mental health. They found her eligible under a different category, which meant I couldn't get her the right services. So we have to think really critically too about what we already have in place and how those systems are or are not recognizing these needs and adapting to address those needs as well.
Yeah, I think what you just said is something that people don't realize. I think most people don't realize how hard it is to get your kids special education support if you need it, or to access mental health services. So like you said, even with a lot of support and knowledge, it can be really tricky to navigate. So I think one of the things that goes back to what we heard this morning is some changes in Medicaid reimbursement. So the free care rule is one of the things that has been put out by the federal government to create, and Illinois has a recommendation for that, and it's been approved, but we're working on the details. But the goal is to move away. Right now, the only Medicaid reimbursed services for kids in schools are those that are already receiving special education. So if your child comes in a crisis, their parental divorce, so they've just lost someone, they cannot bill for those services unless that kid is in a special ed program. So think about what that means. What that means is the people who are assigned to schools right now in places where there's a lot of shortage are assigned based on special education minutes. So that means in Chicago, for example, we sometimes have, a social worker who spends all day doing medical or doing sped minutes delivery of services because there's a lawsuit that they have to do that. And then the gen ed time they get during a week is like an hour. So I go in and say, I want you to do this innovative group program for kids that are experiencing stress and trauma, and that's going to take 2 hours a week. And they look at me and say, I don't have the time to do that. And until we start paying for those services that are being delivered, some of those interventions are the exact same interventions we would deliver at a hospital. But because we're delivering them in school and because the kids haven't been identified as special ed, we don't get paid for them. So philanthropy is paying for mental health. Education is paying for mental health. So when we talk about the systems issues around really changing how we're paying for mental health, and as Dr. Vora mentioned, there's a lot of philanthropy in Chicago. They pay for a lot of mental health services in schools. There's not a lot of philanthropy in the rest of the state paying for mental health in schools. And so therein lies a problem. If we're using the wrong funding to pay for the service, we're not going to have equity. So I think that's a really big piece. I think another one that I just want to build on is this idea that you mentioned around these community connectors or these community health workers. One of the things that we're seeing is some interest in community colleges working to create pathways into behavioral health, sort of low-level frontline providers. So like the equivalent of a para-educator. But one of the things that we haven't done is to create a training program for that or a certificate program for that, or reimbursement for that. So we're in the middle of creating those things. And I think that what we're hearing is the young people want to do this. So if you look at young people who come into our healthcare internships, they all want to be surgeons or sports medicine doctors. But when they spend a summer with us and get exposed to the full range of healthcare roles, lots of them would love to do mental health. But we need to get those kids and get them in pipeline programs. We're not doing that very well. But these certificate programs through the college, the community colleges can get folks trained, get them into communities, be those trusted. It could be the young people, or it could be the grandmas and the volunteers and the bus drivers that are already in line with kids, but they don't feel like they have the skills to do this work. So I think we're seeing some real interest in changing what those pipelines look like, and then also changing reimbursement for things like these extenders, so that I might do a diagnostic plan and come up with, this kid needs to do 10 sessions of exposure to get back into school, but I don't have the time to do that. But these extenders can go and do that work that will help that child get them back to school, and I can then do the diagnostic on the other kid. So we really need to think comprehensively, and I think it's at that intersection of both good ideas and policy and payment that's going to really make the difference.
Yeah, I'm also wondering if you have any additional thoughts on just, ways that local leaders, so again, you talked about philanthropy being really up north, and I would say, as you hit larger urban areas, but when you get into the rural areas, the smaller communities who don't have a lot of foundations really in their space. And again, I grew up in one of those, so I'm speaking from experience. What I do know is that they like to take care of their own, right? They really have a sense of community. And so what are other ways that leaders could possibly advocate for children's mental health in their community, whether that be the government, like their mayors, their town boards? Do you have any thoughts on that? And then again, also to any of the other panelists as well.
Sure. Yeah, I think a lot of what we heard earlier around stigma, right? So I think first of all, people in positions of power in smaller communities, mid-sized communities, large communities need to say mental health and mental wellness are priorities for our citizens. And once they do that, then they can start to really think about what the investments need to be. Safety is a word that gets used a lot to reference some types of behavioral health interventions. So violence prevention, substance abuse prevention. I mean, there's lots of different things we can do, but I think as leaders, it's really centering that mental health is a part of health. We don't have parity in our insurance right now. So asking for that, pushing for that, investing in these kinds of trainings, and really thinking about, what are your citizens most concerned about? As we heard this morning, the one thing that ties us all together is we want our kids to thrive. And we want our own selves to be able to grow in place in the communities that we live. And so how do we do that? We invest in mental health supports, and we do it in these creative ways. But I think it's really, at a public pulpit kind of level, it's stigma reduction, it's including it in your budgets, it's prioritizing it in terms of the training for all your social service sectors, like the police, like the 911 operators. We're doing some work training them on trauma-informed practices, because they're the first line of defense. Somebody calls, and if they don't know what questions to ask, they don't know what kind of help to provide, and they're not able to get kids and families connected to the right services. So it's training and thinking about it as not the problem of mental health providers, but the commitment of the whole community and all of our resources to help health and wellness. And I think that's a paradigm shift that maybe the pandemic has helped elevate, is that if we don't take care of the health of our neighbors, it's going to impact all of us. So that's where we might have an opportunity as well.
Yeah, Angie, sorry, go ahead. Absolutely.
Yeah, I just wanted to add maybe, it's also been my experience that before community leaders are in a place to advocate for children's mental health, not all of them are aware of how connected all the different aspects are. So in their thinking, again, in my experience, and I don't, mean to generalize it for every community leader, but their thinking is often siloed in the sense that, mental health is one bucket, violence prevention is another bucket, substance use prevention is yet another bucket. And when you start to talk about, but all of these things are connected, they look at me like I'm crazy. So maybe just having those conversations, and they're not difficult conversations, they're not long or complex conversations, but people who are in those positions, as opposed to positions like ours or fields like ours even, don't necessarily think of it in that way. But I think that is an important first step before they can successfully advocate for the changes that need to happen.
Absolutely. And so with, you talked about the pandemic kind of being a catalyst to have this conversation, have this dialogue. So Angie, how are the children really doing? And how can we use this catalyst? How can we use the information that you have, or, kind of speak broadly on that, or specific, right?
Oh, yes. So I think in your first question, we kind of all addressed this a little, and just back to that whole, learning to talk for themselves, speak out, share their needs, that really the teachers are saying they're seeing lower academic scores, they're seeing lower SEL and children's just ability to advocate for themselves in a variety of ways because of that loss of, a year and a half of social skills development and those things. So I think that's what we continue to see. And then back to what Colleen had mentioned, the teachers are struggling, the parents are struggling with getting back to what is normal. And it had been mentioned that, the fear of you put a child just out there after telling them don't be around people for years, and then even us as adults, putting you back out there in these groups. How does that continue to impact, and are the parents able to help their children in these ways as well, and thinking of it like that? So one thing I wanted to go back to too was those non-traditional partners in rural areas. I think the whole issue of reducing stigma about talking about mental health, both in youth and adults, and how important that is. Also involving our business leaders. Oftentimes, we're always thinking about healthcare and social service, and how many times groups may have a family member or a friend who they've seen suffer, and how they could be individuals that we reach out to and ask. We have recently started a campaign with our university's athletics program, because younger kids and even adults really look up to those individuals, and what can they do and say, and how can we bring awareness, because we have 20,000 people coming together to follow a team. And so having them talk about mental health and just making it more of the norm to talk about it, I think is really important among all sectors. And how can we do that?
Yeah, and Dr. Scheer, I'm wondering too, like, yes to those sectors, yes to having unique conversations to reduce that stigma and think creatively about how, like, their role in a child's life and a child's thoughts about mental health. But what are the ways, Dr. Scheer, how you think, I know you've mentioned a few thus far, but other ways that we can think about bringing children into the conversation and really ensuring that their voices are also, as we think about community listening sessions, right? It's because we're accessing a new voice that we kind of set aside. So even further, how can we elevate that child's voice?
You can't say it often enough. Listen, ask questions. That's what I'm really trying to preach to everybody that I work with, all the adults, is ask questions and don't make assumptions. I know we were all kids at one point, but the kids that are here now are different, and they face different problems. They have different concerns. And I think what's also really important is to have kids not just at the table as a token. So, instead of having two kids be a member of an advisory group or a council, which is better than nothing. I don't mean to downplay that, but they need to really be engaged in a meaningful way. And so we really need to be willing as adults in decision-making positions to be willing to share our power, and kids deserve a seat at the table in matters that affect them, and have that in a meaningful way. And that's really rethinking how we do things. But I think ultimately they deserve that. And if we want to raise healthy adults, we need to stop treating them as just becomings that are not quite finished yet, and then expect them magically to be responsible and mature the day they turn 18, and start treating them as beings in the present, with agency and with an opinion, again, in matters that affect them. And do take that seriously and actively incorporate them in the decision-making process and all the things that go into those things.
Can you tell people about the Child Friendly City Initiative? Because I think that's an example of that.
Yeah, so the Child Friendly Cities Initiative is a UNICEF framework that is heavily built around children's rights and children's participation. And so the framework has been around for 25 years and has been implemented all over the world and has served 30 million kids. But in the US, it's only been around for, well, it rolled out during COVID in August 2020. And so what we're trying to do in one of the communities in our service region is to do just that, is to engage children and youth in identifying their priorities and giving them a seat at the table. And it's not going to be easy because everybody wants to say that they're doing child-friendly things, but It'll be interesting to see how willing the powers that be are to share their power when it comes to it. But yeah, so we've started engaging kids in focus groups to try to understand what it means to, you know, what are you thinking of when you hear the term child-friendly city? What is it that kids need to be happy, healthy, and safe? If you had a magic wand and could turn your community into a child-friendly place, what would it look like? And like I said before, and those, you know, those things don't come from me, they come from the kids directly. The answers are not the latest, greatest technology or STEM or this or that. And again, I don't mean to downplay this, but they're interested in being able to go outside and play and hang out with their friends and have positive relationships with their friends and have places where they can safely be and safely get to and from places. Not anything really hard, but really hard to implement in the adult world. So.
Yeah, I just highlighted it because it is something that's international, and in the United States, there's a few cities that are trying to do this, and it's tricky because you really do need adults to embrace at a certain level youth participation in order to get the certification. So the process is two-step. You go through an initial needs assessment to create sort of a committee and a plan, and then you have to do it. And I think it's really interesting. And we've been communicating about having Alton and Chicago, for example, both trying to do it at the same time, and it'll look really different, but how do we make that happen? And similarly, it's happening all over the states, and the places where it's happening in the rest of the world, it's worth looking up. So just take a look at the UNICEF program and see how it might be brought to the communities that you guys represent.
Yeah, I'm just shamelessly going to do some advertising. So we were talking about Illinois being, you know, at the forefront of some of these developments. So Alton is going to be the only one of 3 cities. The other 2 are Boulder and Denver and Boulder, who will be joining the second round of pilot cities for the Child-Friendly Cities Initiative in the United States. So it'll be the only city of its size in the United States. It'll be the only city, not just in Illinois, but in the Midwest. So very, very exciting. And like I said before, this is not a UNICEF requirement. We are driving this deliberately. We're going to have an adult advisory board in the community that drives decision-making, but we are going to have a separate youth advisory group, because based on what I do for a living, if you put kids in the same room with adults, they are not going to speak their mind openly. They are not going to discuss the matters at hand openly. The power differentials between children or youth and adults are just there. And so it is very, very important to me to give kids that opportunity, the room to at least have the discussions. You can't take adults out of the equation. I'm not that naive, but I think it's still important to have a separate body that has an opportunity to discuss the matters that are important to the kids, and then determine processes in which the kids can convey those messages to the decision-making powers, and then ultimately codify those and have those set in stone so that they survive from one administration to the next. So lots of very difficult things ahead, but very exciting.
And I'll piggyback off that too. And, you know, we've talked about mandates, we talk about task forces and councils. And through the Children's Mental Health Partnership, a law was passed this past spring to create a youth adjunct council as part of the Children's Mental Health Plan. What I think is really striking is that law was not written by youth. It was written by adults. It was given, you know, I say this as the person who's supposed to be implementing it. It was it was given very strict requirements around how many people were a part of the council. So it only 10 people, and we're talking about trying to represent the entire state. And of those 10 people, 6 were supposed to be youth, 4 were supposed to be adults. But the actual process of creating something that's meaningful, that actually addresses and has youth leading the responses, is much, much more difficult. So I think, for everyone, part of this is also advocacy with your own communities, with those leaders, but fighting on behalf of youth too, because we know that a lot of leaders won't listen unless there's an adult in the room. To make sure that what's happening in Springfield and what's happening in our different mayor's offices, that it's actually, it's not just a response or a knee-jerk response, that it's actually something meaningful.
Yeah, one of the things that I found most powerful in the work that I do, and also just kind of a challenge to all communities, because we didn't get to do it near enough, is while I feel like sometimes adults, we have problems trusting every idea that youth come up with, right? But that, as you said, they need to be involved, but we also don't have one way to solve any problem, right? We have to take it in a multitude of different directions in order to be effective. And so providing that power of choice to a child, like a youth council or whatever, like, this is what we think could work. Here are some options based on the feedback you've given us initially. What do you think, right? And then giving them that power to choose, I think, is so critical, especially after they've been told what to do for so long. So I don't know if any of you have any thoughts on that, but it's something that I know, like personally, when I think about our work in the community or in my work in the community, I wish I would have done it more, and I wish more people will continue to think about how they're providing choice to our youth in the problems that face them in their future people. So,
I could just add, the only thing I would say to that is choice in treatment models too, because as you heard earlier, there's a lot of adults that think kids are going to use mental health services via the web. And what we found is they'll do certain things there, but they won't do everything. And so we need to also, while we've shifted to telehealth, and I think that's really important, giving kids the full range of opportunities about when they want to go peer-to-peer for support, when they want clinical individual services, when they want a quick text check-in, or what they want on their app. So I think we also have to be careful not to just swing so clearly to making
assumption.
sort of ideas about what we think they want. I just was talking to a researcher who said that. They did some real research, and the kid said, yeah, we're happy to do some check-ins, but when it comes to actual therapy, I'd kind of like to be in a room with an adult. And she was surprised by that, because she thought, oh, kids don't like to be in the rooms with adults. They want to do this technology. So I think it's asking the questions, letting them ask the questions, and also making sure we don't just jump to conclusions without doing the research about what actually works.
Yeah, so as we kind of begin and wrap up in order to open it up for questions, just kind of two remaining questions here. And Angie, I'll start with you. What does the vision of putting children first look like from your perspective?
So I think really we've kind of talked about it throughout the panel, is just having children's voices be heard, having that supportive environment around them, just keeping them at the center, and as individuals that are sharing and leading, and then having the resources available for them, whether it be through healthcare and their provider network, or their family and friends in the neighborhood they live in, that safety, safe place to live, work, play, pray, all of those things for kids. And so I think, to me, it's just making sure they're at the center, and then wrapping those resources around them and their families.
Yeah, absolutely. And so then to the panel as a whole, what is it that the federal, state, and local stakeholders can do to work together to enable this vision?
That's a very big question.
Right?
I mean, I think it comes down to coordination. I think it's really exciting to hear about this administration and the coordination that the agencies are doing across each other, that you have Director Vora talking to Director Eagleson regularly, talking to Secretary Ho, who leads the Department of Human Services. But I think one of our biggest issues is that we're not talking enough to each other. And so we keep doing things and reacting that create more mandates and require us to respond, but aren't actually helping. And so how many times a legislator has passed a law for something that already exists, or had they just talked to this one person, they would have known that this was there. And now that law is law. And so the state agencies have to, deal with it. Same with what we're dealing now with the Youth Adjunct Council is it's a law. Had it come from a place more of, I don't mean to critique it, but had it come from a place more of coordination, it would be a little more meaningful rather than us spending time trying to go back and fix it to make it more meaningful. And I think through coordination, then we know, well, that helps us know about opportunities that others might not know about. So from the federal level, they just passed the Safer Communities Act, which provided a lot of funding to communities and a lot of behavioral health funding. So funding for schools, funding for building mental health awareness, and funding for helping to expand partnerships such as between pediatricians and mental health. But who's tracking that? Which agency is tracking it? And how do you make sure that we're taking full advantage of that is absolutely critical. And I think the more that they hear from the stories on the ground of what's needed and that we need to talk to each other to understand it, the more that will happen.
Yeah, I would just add, in addition to coordination, sustainability, right? So making sure that the state, right now we've got a lot of federal dollars coming in, but as these federal dollars are moving on, as we heard from Director Eagleson, we need to think about what the state expectations are and commitments. So I think for me, it's really coordinating where things are going, looking at the evidence of what's actually working, and then investing in those long-term solutions, and recognizing this is not something that you can fix in a 6-month engagement. These are long-term challenges. Kids need to know that those resources that you've built are going to be there from year to year in a school, and they're not going to be gone next year. So for me, it's the coordination and the sustainability of the dollars to make sure that we've got the right resources and the right folks coming together to keep these things going, the solutions that work.
I have two very specific things, but I think still very important. So one, I think larger cities, and I grew up in one, they're fortunate to have people in their private or state organizations that are familiar with the funding streams, that know when they are coming, that know how to go after them. Smaller places often don't. The city administration doesn't have a grant writer. There might not even be a grant writer in the community. So they don't necessarily know what money is available, what they might be eligible for. I can't tell you how many times even I have come across something when the deadline was like a week out, 2 weeks out. I consider myself incredibly lucky if I get 4 weeks. So how to exactly fix it, I don't know. But that's a real problem because that means they can't tap into the funding that is available. The other thing is, to a certain extent, and the maps that Dr. Vora had in his slides were wonderful, but at the same time, a lot of data is collected and presented at the county level, but that also misses a lot of detail. For example, like I said, I work primarily in Alton. Alton is in Madison County. When we applied for a health equity grant, it was grouped by counties, and Madison County was listed as low priority for health disparities because Madison County has an African American population of 8%, while Alton has an African American population of almost 30%. So wrong unit of analysis when you're looking at health disparities. And I can go on and on and on and on about that. So depending on what issue or topic you're looking at, we need to have more data available, and the data needs to be painted with a finer brush than just at the county level, because these issues are complex, and to identify where the needs are the greatest and really concentrate and focus resources, programs, interventions, whatever it might be, on those greatest need areas. We need to know where they are. And right now, I do not believe that that's the case.
And to kind of go off of that, in many of the rural areas, we do not or will not get zip code level data even in the schools, the Illinois Youth Survey that's done, in many of our southern Illinois counties and many of the Illinois rural counties, they have 1 or 0 schools that often complete that. And I think sometimes the schools don't realize the importance of that in bringing resources in, or they don't have the time. It was mentioned earlier that there might be one person doing things and they have like 2 hours that they can put towards that, and it's just seen as another task. So I think continuing to show the need and the importance of all of this data collection is so important. And kind of in summing up all that we've said, between the data and the sharing of resources, raising awareness of the issues, coordination, sustainability, I mean, those are all things that we need. But oftentimes this funding, it's really scary when it ebbs and flows, because you really get going on a project, it's going, you've seen it as a need, and then the funding dies. So that's where, reaching out to places that maybe have this more overall funding, and trying to make funding both at the state and federal level, like how can it address the needs of the community and not be so siloed? Because depending on the year, it seems that there's always a different funding stream that has lots of money. And then we always joke that it's like the health issue of the year or the decade. But we know these issues don't go away. They're still there. So what can we do to get that more sustainable funding to improve the health of our communities everywhere?
How you have to track it and the burden on the organizations to manage that money is also very high. So I think that's the other part when we think about that resource distribution and I think that capacity distribution of those smaller rural areas to then handle those resources, and not handle because they won't do good work, but just the sheer reporting that's required. So,
And picking off of that too, I think when we talk about resource allocation and sustainability, and whether or not you even have staff available to pursue these things, is to think also about how the effect of those two things actually has on the workforce who's trying to apply for it. So when you're someone who's free every year trying to just hope you get funding that will pay for your job, what does that do to you and the burnout rates? And then you cycle out of the system, and then we don't have institutional knowledge anymore. We miss opportunities. And so also thinking about all of these issues from the adult mental health perspective as well, and how it's impacting us, I think is absolutely critical too, because, we talk a lot about Medicaid, but, half of the youth in the state are privately insured. And most, I don't know the exact numbers, but we have lots of therapists who refuse to accept private insurance or Medicaid because of the burden of reporting and making sure you're being reimbursed properly. And is anything going to fix that? Even if we increase their rates, are they still going to want to deal with the bureaucracy? No. So they're not going to re-enter the system. So we have to also think about what we're putting on the workforce as we're trying to address these issues.
all right. So are there any questions out in the audience or virtually? Yeah. So the question we have is, is there a county, a city, who's doing it well, whether it's in Illinois, in the country, that we can look to as a model?
I'm not sure we have all the answers, and I'm not sure this is what our state wants to hear, but places where they've allocated resources to mental health very specifically are doing better. So, for example, Colorado, a lot of their marijuana money is going towards mental health. In California, they have a millionaire tax, and that money is specifically designated for mental health. So I think it's prioritizing where the money's going that we're seeing the most innovation. And that doesn't mean that we're trying to do a lot of the same things, but for me, it's that sustainability of funding. It's knowing that I don't have to go get the next grant to try to keep this going. It's knowing that I can plan a short-term and a long-term implementation strategy that's going to work. So I think from my perspective, as I look and listen, and I just came from, a national conference, I think Illinois is actually doing a lot of really cool, innovative things. I just think that we're doing them in starts and stops and fits and starts. So I think people in our community, because of things like the partnership that's been around for 20 years, most states don't have that. Most states don't have people who've spent the last 15 years with a Child Trauma Coalition. They're now coming up with some ideas. So we're in this place where we've had these sort of pieces, and if we can get folks to elevate that and make them long-term policy, I think Illinois actually really could be a leader. We've been very clear, for example, there's lots of states claiming that they're trauma-informed states. And we had some people that wanted to do that here. And we said, please, don't do that. Don't go out and say we are something that none of the citizens in our state can actually feel when they walk into our agencies. So we're really trying to bring that rigor to say, look, if we're going to make an announcement and say that this is something that we are doing in our state, how are we all coming to the table to do that well? And I think the places where I see the most progress are the ones that are holding to that. And they're really putting out metrics and data and looking at it at the micro level, like you said, the zip code level. They're really taking the strategies and in some ways putting their money where their mouth is and really saying that this is something that has to last and be important no matter what.
Colleen, I think you said this. You shared that youth don't want to use telepsychiatry in all cases. And at least our hope in Hillsborough was that we would be able to reach youth through telepsychiatry. Could you be a little bit more specific as to what, or maybe when they want the adult in the room so that we're not trying to push something on them they're not going to use?
I don't think we have the answers to that. And that was data I hadn't seen before, to be honest. So I think these are the questions we need to be asking. So from my perspective, I was one of those people pushing for telehealth because I believe it'll increase access. And I know that it has. And I want our insurance companies to continue to cover it. I think the question of what intervention, where and when and how is a question that we can't ignore. So from my perspective, what we need to be doing is looking at the data and looking and actually seeing, do kids who are experiencing anxiety, are they responding to telehealth? Are they able to use an app to go practice some of their exposures, for example, in ways that we haven't seen before? So I think the issue that I have is I think we need to be out there doing the actual research of figuring out what, when, where. Sometimes we're so behind in delivery that we're like, get them anything, right? And so I think that the telehealth, like you said, we all were hoping it would just be the solution. Some things are great, like parent training in telehealth is fantastic. Because guess what? When you bring them to your office, they look different than when you're in your house. So if you're actually able to coach a parent on how they're managing their child's behavior in the home where they actually live, we're seeing a lot of great uptake on those skills, right? So there's things that have to do with generalization that we need to look at, things that have to do with, is this a skill that we need to learn? Is this a skill that is best delivered in a group setting where they can problem solve with their peers? So I think we really have to get to the point where we have enough options and we have the investments to start to think about what's got the best impact. But I don't think that research has been done. We've seen increased access, so that's good. But now we need to figure out, are those services that people are accessing helping them to get better on both their symptoms and their overall functioning? And I don't think we've answered all those questions yet.
Growing up a few years ago, I didn't deal with social influencers. And I wanted to know the panel's reaction to the growing number of social influencers that students and people look at. Does that impact mental and social behavior? And how do you at the schools and whatever deal with that? Is that something that we as a community need to, improve our social influencing, I mean, how does all that work? That, like I said, this is new for a couple of us that did not grow up with that. But I think that it connects in with telehealth. How do we use it positively?
I'm going to speak as not so much the expert on this, but a parent of teens. So, and what we always, and even in some of the school health things, is just the importance of looking at it from the lens, like what is this individual putting forward? They're putting forward this best look at themselves or this certain image or whatever, but in their real life, is it really like that? And just talking to them about realistic expectations and what is real and what is not. And because I always ask my kids, where did you see that? Or where did you hear that information? And my 13-year-old says, TikTok. I'm like, okay, well, let's look it up at a reputable site and see what they say. And then it's always turning it to this educational thing. And she's taking that back to her friends and said, well, you know what we saw on TikTok? This isn't really what, we looked it up and I don't know. And that's as a parent perspective, just making them realize that that is not real. And that individuals are putting their best, whatever they consider the best thing forward. And in bullying prevention, that's kind of, years ago, those are some of the things we always talked about. And just general health education theory is, where are you finding your information? And a lot of times TikTok and Snapchat and social media and Be Real, none of that is the real deal.
And I think it does go back to bullying prevention. And so I think some of the same strategies. I think one of the things we have to make sure of as adults is that we are actually in those spaces with young people. I think one of the things that really worries me is we hand over this phone to young kids. It's more powerful than the computer I wrote my doctoral dissertation on. And yet we don't realize that we need the same kind of bumpers that we would give them when we teach them to drive. So I think adults need to be really careful not to just say, well, that's not my space. So what we are looking for in the bullying prevention world is really that idea of how do schools and parents work together, because schools are being held accountable for things that are happening. And increasingly, you say something on a field trip, you say something on your way to a basketball game, you can get in trouble. But we're sort of, whose job is it to be actually on these spaces with kids? And I think when I really think about the factors, certainly social influencers, bullying, all of this stuff, kids are spending an awful lot of time here. And the people that are impacting them, if you're not in that space with them and monitoring it and having conversations, you're really giving a lot of power to people who you've never met. And so I think that's where, again, a lot of the themes here are around, I can say all of that. I get lots of calls saying, we need a bully prevention program in my school. And I say, that's really good that you're asking, but let's start with your social emotional learning strategies. What is happening in your school? And then what we know is just say no to drugs didn't work very well. Just say no to bullying is not going to work very well. So how are we going to teach those skills? But also we got to engage. So if we just sort of turn it over and say, that's not my thing, then we're going to get what we're getting, which is a lot of dangerous behaviors coming out of those settings. So we do have to kind of force ourselves to enter into this new world, or at least have younger colleagues that can help you navigate, because I gave up. My girls are 21 and 25, so thank God I'm not monitoring this anymore.
I have a 10-year-old that acts like she's 16. But yeah, so I think it goes back to critical media literacy. And unfortunately, as a result of a lot of very complicated processes, the schools have been stripped of the power to teach a lot of critical thinking. Let me just say that. But I try to tell my kids that, God gave you a brain for a reason, use it. Does that make sense? Why are they telling you that? And keep in mind that they're getting paid for it. Because one of the things in a different field, it was nutrition related, but one of the things that they found through a study was that worked surprisingly well on changing kids' eating behaviors in schools was telling them that they were being duped by the large companies and by the marketing. And kids and adolescents really do not like to hear that. right? And so telling them that somebody is just, they're selling them a product. They're selling them a story. And I think they need to know that. My gut instinct as a mom is to roll my eyes and say, oh, TikTok again, really? Where did you hear that? That doesn't make any sense. But it's not that easy, and I can't pull myself out of that responsibility that easily. And so it really comes down to this, having the conversation in general, because you're not there for every single issue. You're not there for every video that they watch, but just making sure that they are able to question what they see. Does it make sense? Why are they telling you that? And what's in it for them, right? And I think that is a broad thing that is hopefully applicable to most of the videos that they are exposed to.
And not that I'm an expert, but I think, just given, again, my experience and also conversations that I've had with my cousins who are now in college, I think it's important for us to not overlook the relationship they have with that phone, because who they are online is also not necessarily who they are outside of the phone. And so how that impacts how they want to interact with an adult then may also come into play. And so again, I am not an expert, nor have I read a research paper on that, so I probably shouldn't have shared. But that is all the time we have. Oh, one more question. I have been told we have one more question. Sorry.
We have a question from chat, which mentions, what specific collaboration with school districts can incentivize teachers to sponsor after-school clubs, sports, etc., which support the mental health staff in maintenance of healthy social interactions for children and youth? Yes. What specific collaboration with school districts can incentivize teachers to sponsor after-school clubs and sports which support health staff in maintenance of healthy social interactions for children and youth?
I'm hearing that question also in a couple of different ways. So
I would be happier if we got community members engaged in doing that, which would bridge a lot of gaps in terms of, parent and community engagement and relationships between schools and the community, because the teachers I work with have more than enough on their plates, and they are overworked and underpaid. Not sure if just paying them more would fix the overworked problem, probably not. So yeah, the after-school programs are needed. I'm not sure if teachers are the right group of people to look at to fill this gap. I think there's a lot more potential in working and collaborating with the neighborhoods the schools are located in.
And I'll add, I think the other piece of that equation that's missing is thinking about how can we make sure that kids can even participate. So there's, I think for many communities, a lot of assumptions about kids having the time to do debate or a sports team, but there are a lot of kids who can't do that. I was one of those kids. I didn't participate in anything. I was dealing with parent mental illness my whole childhood. So you have kids that can't participate. And so I think if you want to incentivize anyone to have those programs, you also need to provide resources to families to make sure they're in positions to allow kids to be kids.
And this is a topic I do feel comfortable just sharing some closing thoughts on. I think it's also important to realize that teachers don't want to say no. I think it's a self-protection measure, because when they hear, oh, do you want to bring in this program? It's usually also then coupled with, and we need your time, and we need this. And so Dr. Scheer, you really talked about that. So just ensuring that, when these programs are being developed and when these programs are being approached to schools, is to also then say, and we have these volunteers, and we have this training, and we have this, because it lowers their defensiveness when it comes to implementing those within their programs at their schools. So with that, we are 1 minute over time. I want to thank the panelists so very much for their expertise today and the audience questions. And thank you again for the honor of really getting to dialogue with you all today. Have a good rest of your lunch and afternoon.